Great. Thanks a lot, Dr. Lang. It's really an honor to be invited to speak on this topic here to you all. And so, I wanted to talk about radiation and the level of evidence that has come out in the last 10 or 15 years, supporting the use of radiation, not only radiosurgery, but also whole brain radiation, and how that technique has evolved with time. And this is a theme that has been echoed by Dr. Lang and Dr. Ferguson. There have been significant advances in systemic therapy, which render our population of brain metastases patients different than the population of brain metastases patients that were treated in prior eras. And so our focus has evolved, and we now are interested in strategies which limit toxicity, while at the same time providing durable intracranial control. And so many of the recent prospective clinical trials now use cognitive preservation as a primary endpoint. So I'll highlight that as we go through some recent data. So let's first start talking about the role of whole brain radiation and how it's evolved, how whole brain radiation is supported with level 1 evidence at this time. So clearly whole brain radiation is widely available, it's well tolerated, it can be started quickly, it is very effective in treating microscopic disease, but there are established side effects, including the concern for late toxicities, including neurocognitive toxicity, limited efficacy in radio-resistant disease, and then the time off of chemotherapy that's required. So what can we do to minimize the cognitive decline following whole brain radiation? There have been two strategies that have been tested in the cooperative group environment. The first is memantine, and the second is hippocampal sparing whole brain radiotherapy. And so I'm going to talk about these two strategies now. So in RTOG 0614, a cooperative group trial performed in the United States, it was a phase 3 randomized study looking at the role of memantine in patients receiving whole brain radiotherapy. These patients were randomized to a placebo or memantine, and the primary endpoint was neurocognitive preservation as measured by the HBLTR score at 6 months. This study was led by Dr. Paul Brown. And they found that the cognitive function failure rate was reduced with the addition of memantine. There was a lower probability of cognitive function failure at 24 weeks. And it was very, very well tolerated. So this became a standard of care for patients receiving whole brain radiotherapy. Now, in parallel, the development or the advancement of radiation techniques, including intensity modulated radiation, has opened some possibilities about regarding dose shaping within the brain. And preclinical evidence has have suggested that perhaps there may be some clinical benefit to avoiding the radiosensitive stem cells near the hippocampus. So investigators led by Dr. Vinay Gandhi helped develop the rationale for sparing the hippocampus when performing whole brain radiotherapy. This led eventually to the development of the NRG cooperative group trial CC001, which is now published, looking at the standard of care arm memantine with conventional whole brain radiotherapy and comparing that with memantine with hippocampal avoidance whole brain radiotherapy in patients with brain metastases. Here's the schema for the trial. Patients with brain metastases were stratified by RPA and prior therapy and then randomized as I described. It's important to know the eligibility criteria on this trial. Patients were only eligible if the brain mets were 5 millimeters outside the hippocampi. They must have had an MRI scan and there could not have been any evidence or suggestion of LMD. The primary endpoint, again, time to neurocognitive failure. For the radiation oncologists in the audience, the CT was defined as the whole brain, and the ultimate target was that structure minus a hippocampal PRV of 5 millimeters, and that was treated to 30 gray and 10 fractions. The hippocampi were then limited to a fraction of that dose schematically, or it looks like, illustratively, it looks like this. So on the bottom, we see the standard whole brain radiation with a uniform dose across the entire brain to address both gross and microscopic disease. On the top, we see the hippocampal avoidance technique by which bilateral hippocampi are spared from the prescription radiation dose. And they found that hippocampal avoidance reduced the risk of neurocognitive failure. The curves separate at about 3 to 4 months and maintain their separation long term. So for patients without limited brain metastases, hippocampal avoidance with memantine is a favored strategy over standard whole radiation for neurocognitive preservation. But please keep in mind, this is particularly relevant for patients with intermediate to favorable prognosis, at least 4 months, no evidence of leptomeningeal disease, and no metastases within 5 millimeters of the hippocampus. Now let's shift our attention to the patients with limited brain metastases. Is there a role for whole brain radiotherapy in this patient population? This has been well evaluated in multiple large phase 3 clinical trials. There have been 4 trials in patients with 1 to 3 brain metastases evaluating whether the addition of whole brain radiotherapy to SRS is indicated for patients with limited brain metastases. In summary, the addition of whole brain radiotherapy does improve local control of gross metastatic disease in the brain. It does improve distant brain control. But despite that, despite the improved intracranial control, patients consistently demonstrate impaired neurocognitive function long term. And the addition of whole brain radiotherapy does not affect overall survival. So the first study published in 2010 from EORTC looked at 350 patients that received local therapy for limited brain metastases and then were randomized to the addition of whole brain radiotherapy or not. And again, whole brain radiation added better intracranial control and did lower the risk of neurologic death. But in subsequent studies, including the Aoyama trial from Japan, there was no impact of whole brain radiotherapy on local control, distant brain control, overall survival. And this led eventually to the modern evaluation of these patients with limited brain metastases in 2 trials. The first was the single institution randomized control trial led by Eric Chang at MD Anderson, in which patients with SR were randomized to whole brain radiotherapy or no whole brain radiotherapy, receiving a dose of 30 gray and 12 fractions. This is one of the first randomized trials to incorporate a validated set of neurocognitive testing and use that as the primary endpoint. The trial was closed early by the Data Monitoring Safety Board. And because whole brain radiotherapy was associated with significantly worse cognition at 4 months. At the same time, the Alliance group ran a multi-institutional clinical trial, which I'm going to get into more detail in the following slides. So in the Alliance trial, N0574, led by Paul Brown, patients with limited brain metastases, 1 to 3 brain mets, were randomized to SRS alone or SRS with whole brain radiation to a dose of 30 gray in 12 fractions. The SRS was delivered as shown at the bottom of the slide, where there was a slight reduction in dose if they are randomized to the combination arm. The primary objective was neurocognitive preservation at 3 months. Patients with 1 to 3 brain mets were enrolled. There was no prior surgery, obviously no LMD on the trial. 34 institutions participated and patients were enrolled over a 10-year period. The median follow-up was 7 months. And the primary endpoint was met. Cognitive progression at 3 months was worse in patients that received brain radiotherapy, despite the fact that the whole brain radiation dose was relatively low, 30 gray and 12 fractions. And this finding was persistent at 6 months. And now it's important to highlight that the primary endpoint was powered as a drop of 1 standard deviation in any one cognitive test. but this finding wasn't limited to one cognitive test. As the authors demonstrated, the decrease in neurocognitive function was across multiple domains, as demonstrated here. No surprise, the addition of whole brain radiation improved intracranial control. But despite that finding, neurocognitive preservation was worse in the combination arm. There were other radiation side effects noted with the addition of whole brain radiotherapy that we're all aware of, alopecia and dermatitis. The necrosis rate was not significantly different between the two arms. Quality of life was followed in a study, and quality of life was improved in patients that received SRS alone relative to the combination therapy. And again, this is across multiple QOL domains. So the authors concluded that the addition of whole brain radiation is associated with a more frequent decline in cognitive function across multiple domains, and also worse quality of life. The improved intracranial control was noted with the addition of whole brain radiation, but did not impact overall survival. So let's shift our attention now to patients that don't have limited intracranial disease, the population of patients that have 4 or more brain metastases. The standard of care, according to most historic guidelines, is whole brain radiation for patients that have at least 4 brain mets. But evidence started to emerge, showing that perhaps we shouldn't treat those patients with whole brain radiation discriminatorily because their prognosis may not be that worse than those patients with limited brain mets. So Yamamoto et al. Published their experience of treating 1,200 patients with up to 10 brain metastases with SRS alone, and compared the outcomes of those that had 2 to 4 brain mets with those that had 5 to 10 brain mets. And they found that there was no difference in their overall survival and no difference in their MMSE long-term. And so they suggested that SRS might be a suitable alternative to patients with up to 10 brain metastases. This led ultimately to the development of a single institutional randomized controlled trial led by Dr. Lee at MD Anderson, in which we enrolled patients with 4 to 15 brain metastases to SRS alone versus whole brain radiation alone. This is a trial that actually first started as a study looking at 4 to 10 brain metastases, but ultimately that was expanded. These were for non-melanoma brain metastases patients. And they all had a reasonable performance status, no prior whole brain radiation. They could have received prior SRS to 1 to 3 brain mets. The patients were randomized to SRS alone, 1-to-1 with whole brain radiation, with memantine strongly encouraged after the RTOG trial was published in 2013. The primary endpoints, there were co-primary endpoints, memory function at 4 months, as well as local control at 4 months. The median number of METs for patients enrolled on this trial was 8, so please keep that in mind. And what the authors found, and this was presented at ASTRO in 2020, the manuscript is still pending publication, but what the authors found was that the SRS alone was associated with improved neurocognitive preservation at 1 month and 6 months. Now, the trial was closed early because of slow accrual and then ultimately subsequent to the publication of CC001, the hippocampal avoidance study. But despite the fact that the study was closed early with 18 enrolled in the SRS arm and 13 enrolled in the whole brain arm, there still was a discernible difference in neurocognitive outcome. And this was across domains. A global cognitive function measure was used called the Clinical Trial Battery Composite Score, which looked at the mean Z-score across multiple domains and measured the change from baseline. Cognitive composite scores were noted in the SRS alone arm at 1, 4, and 6 months. Again, despite the fact that the trial was closed early with limited numbers in each group. Other endpoints that were looked at, local control at 4 months was no different. Distant brain control was actually not statistically different, but numerically you can see that the whole brain arm had better distant brain control. There was a shorter time to systemic therapy with the strategy of undergoing SRS versus whole brain radiotherapy, and it was well tolerated. So again, SRS was associated with a reduced risk of neurocognitive deterioration compared to whole brain radiation in patients with 4 to 15 brain metastases, as demonstrated by advanced validated neurocognitive testing. And there was no difference in overall survival. So now let's shift gears again and talk about the role of whole brain radiation after surgery. As Dr. Ferguson highlighted, the PATCHEL study looked at 95 patients with a documented resection of a single MET, and they received either whole brain radiation or observation. The primary endpoint was recurrence of brain disease, and what they demonstrated was the addition of radiation following a surgery improved local control at the surgical site as well as distant control in the rest of the brain. And I'll get back to that in a little bit. Let's talk more specifically then about the addition of whole brain surgery to whole brain radiation. Again, the addition for a single brain met, the addition of an aggressive local therapy did improve local control and even overall survival in this patient population. So how do we best manage the surgical cavity after a surgical resection? There's 2 studies I want to highlight with my remaining time. The first is the MD Anderson trial, co-led by radiation oncology and neurosurgery in patients with limited metastatic disease, in which patients after a gross total resection were randomized to SRS versus observation. And then the NCCTG study led by Paul Brown, patients with limited brain mets randomized to SRS versus whole brain radiation. In the interest of time, I will just highlight that the doses were slightly different on the 2 trials, given the fact that the MD Anderson trial were looking specifically at patients that had a gross total resection, as validated by the study radiologist. The doses were reduced on the study. And so this is the MD Anderson data showing that the addition of SRS to surgical resection improved local control at the surgical site significantly. Although I should point out that the 12-month local control of 72% was a little bit lower than what we had expected. And that may have been due to the down dosing. There was an interesting finding of an increased, higher than expected risk of LMD. And this has led to the development of an ongoing clinical trial looking at pre-op versus post-op SRS. Finally, I'd like to talk about the Alliance trial, the N107C. Again, patients were randomized to whole brain radiation versus SRS following a surgical resection at the neurocognitive primary endpoint. And again, the addition of whole brain radiation led to worsening cognitive preservation. Okay, so so the standard of care for patients undergoing surgical resection can be SRS alone. There's no difference in overall survival with the addition of whole brain radiotherapy. And in the interest of time, I'm just going to skip ahead. SRS was associated with less radiation-related adverse events. So there's no difference in survival between whole brain radiotherapy and SRS to the surgical cavity, but whole brain radiotherapy does introduce a worse cognitive outcome. Okay, so in summary, what I'd like to point out is that as we move from observation to SRS to whole brain radiotherapy, local control can improve, but the trade-off is worsening neurocognitive function. And there's no improvement in overall survival with more comprehensive treatment to the brain with whole brain radiation. So competing risks of intracranial progression and the potential late effects of whole brain radiation make patient selection particularly important. An outstanding question is whether hippocampal avoidance whole brain radiation with memantine is a better strategy than SRS alone for patients with grade 4 brain metastases. This question is currently being asked in an ongoing cooperative group trial led by multiple cooperative groups. So our practice is to treat patients with SRS, particularly if they have extended prognosis. We don't limit to just 1 to 3 brain metastases, and select patients will extend that beyond 3 brain metastases. If we are going to use whole brain radiation, we do favor memantine with hippocampal avoidance. So again, thank you very much for the opportunity today. And Fred, I'll hand it back to you.